Thank you very much. I'm Steve Montgomery Laird. I'm one of the consultant physicians in medical microbiology. I was trained as an ID physician and a medical microbiologist, and I work in the UK in the West Midlands area, covering 3 different states serving a population of about 2 million people. Could I just ask a favour, if you guys are not talking, could you just put your disclaimer is that currently I am working with Prof. Viscas on some of the brilliant work that he's doing with Sepal. So when we talk about topical antiseptics and antimicrobials, I just want to make you guys aware that that is in the background. This is a huge amount of stuff to try and talk through in 20 minutes, and I'm basically going to give you an overview to try and set up the scene of reminding everybody about what chronic leg ulceration dominant, because that's where we dominantly see it, sacrum and the legs, are, what causes those leg ulcerations as a quick reminder to us all. And then I'm going to start getting into the microbiology and the antimicrobial aspects that we and the principles that we stick to with the evidence base that we have from NICE, which is the National Institute of Clinical Excellence, our body, which one of its primary focuses is to bring about good evidence-based medicine. And then I'm going to ask you guys to make your own conclusions on whether you think we're at that point in 2023. So just reminding everybody, what is a chronic ulcer? Definitions are really important. They're very important when it comes to research, especially, but in medicine, if we don't have a definition of what a disease actually is or a process actually is, then we can't bring together information from multiple sources to try and look at it from a pathology point of view and from a microbiology point of view, and then obviously to focus in on a treatment. So the basic of a chronic ulcer is a full thickness skin loss for over 3 months, which has no ability to self-heal within itself. There's many causes, as we've just touched upon in the opening statements, but the dominant cause worldwide is still chronic venous insufficiency. So these are venous ulcers, which we see in a lot of people, and we see that around about in 70% of chronic ulceration. The second commonest cause is still a vascular cause, which is arterial insufficiency. And then we see other things which are usually related to diabetes or underlying diseases, such as neuropathic ulceration or dominantly diabetic ulceration, through multiple different causes, vascular, immunocomplex, etc., etc. We talked about this a couple of years ago, and I'm not going to talk about diabetic foot ulceration specifically again. The unusual infective causes that we see, that we keep in the back of our mind when we're thinking worldwide, are things like leishmaniasis. We do see leishmaniasis in the UK, not endemically, but when people come back from places like West Europe, so Spain, the south of Spain still has leishmaniasis in its dog population, and all the way through the Mediterranean, right down to the North Africa and through Northeast Africa and the Arabian Peninsula. So we do see things like that. We don't see much of Mycobacterium ulcerans anymore, not in this country, even as an imported disease, but we do still see cutaneous forms of tuberculosis, of which the UK still has a significant proportion of people with TB in its multiple forms. So these are just all reminders. These slides are quite heavy, but it's just about basic principles, that there's lots of causes, but there's lots of underlying health causes as well, which will lead to chronic ulceration. And that's one of the thought processes that you must have when you're talking about chronic ulceration, because you need to get to the bottom of the problem, sort out what you can with regards to the disease process to stop the skin from breaking down or allowing healing to be inhibited. It's not all about infection, and this is what I talk about day in, day out as a microbiologist. So how do we define an infected chronic ulcer? Well, we put the chronic ulcer part in there, the full skin thickness loss over a 3-month period. And then we add in 2 of the following clinical signs. So is there erythema? Is there pain? Is there pleural discharge? This is, again, what NICE has defined as an infected chronic ulcer. We usually see a lack of healing, and then we're worried a bit about whether or not there's an infection, but sometimes they don't have 1 or 2 of these signs with that lack of healing. And that lack of healing might be because of poor vasculature, and that's sometimes a problem. You will have to, I do apologise, I am holding the fort at Warwick Hospital by myself today as the microbiologist, so I won't get that, but you will hear phone calls. I always talk about the microbiome of everything when it comes to microbiology. It's super important for one reason and one reason only. What I compare it to is, if you are training as a general physician or as a cardiologist, you listen to hundreds and hundreds of hearts which are normal, and then you now and again will hear that pansystolic murmur, you will hear that ejection murmur, and that's when you know that it's abnormal. So if you do not know what is on the skin as a commensal, then you can't define truly, when we're doing gross swabs at surface areas, what is abnormal or what is normally abnormal. So those common organisms that we pick up from the skin when we're doing swabs, we shouldn't be treating every single one of them. And in chronic leg infections, especially on ulcerations, with those nice moist areas, with a reduced immune presence within that area, we will see lots and lots of different organisms. Sometimes we're lucky and we just get one, and we'll get something like a beta hemolytic strep, and we'll be happy about that, focusing in our targeted therapy, given gram-positive cover only. But sometimes, I'm a wanted man this morning, but sometimes we will see things which shouldn't be there, but may come directly from consequences of being bedbound. For example, we might see coliforms within the ulceration. Coliforms are not supposed to be there, but we know that they do colonize. If it's a predominant coliform with nothing else causing problems and clinical signs of infection, then we're going to target that coliform, that weird thing that shouldn't be there, whether it be a Proteus, an E. coli, etc., especially if it's profuse and our gram-positive cover isn't working, we will end up giving gram-negative cover. We talked about all of this before. I'm not going to talk about it again, but there's a lot of different things which will stop healing, and there's lots of different things which will alter slightly the microbiome of a patient's body, whether it be the sex of the patient, the hormone cycle that they're in that part of their life, or whether it be damage to the skin, or what they've been shown to have with regards to the colonization of that area. For example, in the United Kingdom, we don't have a lot of MRSA colonization compared to the United States, which they have a huge amount more MRSA colonization, probably because of the selective pressures of the amount of antibiotics that they used in the early 2000s and the 90s. So we have to think about things like that as well. But grossly, that microbiome that I showed you before is what an average person globally will have. But these are all of the other considerations that we must have to think about. So this is taken directly from the chronic ulceration management advised by NICE. So we have to think about the causes. We have to think about colonization versus pathogenicity. We have to think about whether or not this is truly infected, because a lot of people will just swab ulcers in primary care, in family care, and send them into microbiology. We will find something, we'll try and suppress what we need to suppress with regard to what we think is a colonizer. But sometimes other things will go out and they'll be treated and have inappropriate antibiotics. So we have to think about all of these I think personally, wound infections and chronic ulcer infections are one of the most complicated things to treat from a microbiology point of view because of the polymicrobial aspect and because of the underlying disease. But you guys can read this in your own time. This is how, in general, we will deal with a chronic ulcer. This is what we choose as a systemic first line, and a lot of the trusts. So trust is an area in which there's usually a secondary care or a tertiary care hospital with a surrounding primary care, family hospitals in that area. So my trust has 3 big hospitals, 2 secondary care hospitals and a tertiary referral centre. And this is pretty much what we'll use as well. We'll use for chronic wound infections, we'll use predominantly gram-positive cover, ideally flucloxacillin in a high dose, or vancomycin for those who are penicillin allergic. And then we might start thinking about, actually, do we want to start treating the gram-negatives that are present? Do we want to treat the MRSAs that are present as well? Because we know that Staph aureus can be a commensal and it can be pathogenic. That's where it gets tricky. So this is the guidelines that NICE have, with a huge amount of choice, but we really do have to put all of those aspects together and come up with a strategic plan to make sure that we are very good antimicrobial stewards. Now, if there was a time that we didn't have to give systemic therapy and we could only give topical therapy, that would be amazing. If we could give something which would deburden, decolonize, and take away the pathogenic strains of the organisms that are in the wound itself, that would be probably the gold standard, rather than giving systemic antibiotics which affect the whole biome of the whole body. So what evidence do we have for that? This is all we have. You guys might have read this quicker than I've got to it, but from the NICE guidelines from 2020, all we have is one systematic review of antibiotics and antiseptics for venous leg ulcerations. And from these points that I've summarized from those many pages of information, this is what we've got. We've got 45 RCTs. 9 of them were not included because we didn't understand them. They weren't scientifically well written. We didn't understand the interventions. And actually, one of those studies was poor enough to be withdrawn from publication. 7 RCTs included people exclusively with leg ulceration infections. But again, coming back to that very important point of definition, that definition was uncertain and infection wasn't known for absolutely. So when you're bringing together in that analysis, in that systemic analysis, that kind of meta-analysis, how do we bring together certain informations to give certain significance of certain treatments if we don't have a defined illness and a defined end outcome? We can't. It can't be a homogeneous analysis. 14 of the RCTs included people with leg ulcerations of unclear infection status. Again, that's not helpful. And 15 studies included people with leg ulcerations that were not infected, which is somewhat useful because the end outcome of looking at this analysis is about healing versus using an intervention versus placebo. So the things that we use in the United Kingdom, or the things that have been looked at in the United Kingdom, which may be similar to India and the rest of the world, are iodine-based preparations. So in one single RCT, it was shown that there was significance over standard care, and that was at eliminating the presence of Staph aureus. So good, there is that. But there was no significance when compared to something like silver dressings, and especially from the frequency at 12 weeks of healing. So we can add things on, and we know that we can clear, but we always have to be in the back of our mind concerned about the healing aspect as well. So decolonization shouldn't just be the end out point. which it wasn't in the iodine studies. We did look at the size and healing potential of the tissue. But what we're really looking for with all of these preparations is good antimicrobial and antiseptic availability without damaging the underlying granulation tissue. And if in fact we can find something that speeds up healing, that's excellent. But if we could just allow natural healing to occur as well without reducing natural healing, also an excellent outcome. I don't know if you guys have put these pads on. We don't just tip iodine on like you do in surgery. They come in all different types and shapes and forms. And in these RCTs, they were mentioned, they were different forms of preparations in which they could be used, whether they were the pads, whether they were roll-on stickers, etc., whether they were induced in bandages. But again, a lot of the information varied from different types of preparation of iodine. When you're looking at the uninfected ulcer, there was no significance from the difference from the iodine preparation to paraffin gauze. So again, is it helpful in healing? Probably not. And then in all of those samples that we used a different base products, such as peroxide, there were no real studies that were done on infected leg ulcers. These were all whether it was very, very unclear, again, back to definition, it wasn't there, whether or not that leg was infected. But it did show that peroxide-based preparations was significantly better than saline dressing for reducing the average size of the ulcer. Take that from what you will. I'm sure that will bring about a lot of discussion, because as we know, peroxide can be quite damaging towards new, fresh vascular granulation tissue, but it has been used for many years. Was hydrogen peroxide significant for those in the uninfected leg? Well, it seems like it was from this very, very small set of RCT studies. It does seem that it did have some form of effect. We use honey-based preparations a lot in the United Kingdom. Silver-based preparations and honey-based preparations, probably our go-to with some iodine preparation stuff as well. So having a look at the unclear leg infection status, which is a shame because we know that honey directly has antimicrobial effect. All we can say is that in the unclear leg infection, honey was not significantly different from the standard care of treatment in the overall healing at 12 weeks. In absolute uninfected leg ulceration, again, honey wasn't shown to be significant from when you're using this type of hydrogel pad for the eradication of MRSA at 4 weeks. Again, it's a shame, but I think that because we use it an awful lot and we still continue to use it, yet the evidence shows that it doesn't actually make a difference in the uninfected leg ulceration. Silver-based preparations I touched upon, we do use them an awful lot, expensive, but useful. And actually, again, the NICE guideline has given us the evidence that silver dressings were not significantly different from non-adhesive dressings for adverse effects, but they were significantly better than the non-adhesive dressings plus a compression dressing for healing at 9 weeks. So I'm glad that we continue to still use them, although they are expensive. The unclear leg infection status of silver-based dressings showed that there was no significant difference to the follow-up at 4 to 12 weeks. That's essentially what that very busy slide says. But there was, again, so we shouldn't really be using silver-based dressings in the uninfected leg ulcer, but we do, because there didn't seem to be any significant difference when compared to the placebos or compared to standard wound care dressings such as non-induced, non-absorbent non-stick pads. So silver dressings plus compression, however, was significantly better than a non-antimicrobial dressing plus compressions for reducing ulcer surface area when measured using square centimeters at 4 weeks. Is that the silver dressing or is that the compression dressing? And I think that's a difficult one to tease apart, especially when the majority of these 70% will be ulcers related to venous insufficiency, and we know compression dressings have a positive effect on wound healing at that point. Okay, so I'm going to wrap up that talk. I hope I wasn't too quick. I hope I'm on time. And it's just really for you guys now to think about, is there something better out there? I'm not going to plug Settle, but you know, when we've got something that is of natural base, that works well on patients with no effect, that has good outcome and decolonizes without giving systemic effect and the adverse effects of systemic antibiotics such as C. diff related infections, then should we be looking into that kind of research a lot more, as this problem is so common worldwide. Those are my references for this. Thank you very much for your time. Questions, are we taking questions at the end? Yes, sir. Amit.
Oh, hi. Very good presentation. Actually, I was looking forward to hearing what you have to say about this difficult topic. I've got plenty of questions, but I don't think I would be able to ask all of them. But if you don't mind, there are three main things that came to my mind after listening to you. So one thing was, I want to know, do you still have, is there any role of culture swabs? Do you still recommend them to be done for the leg ulcers? Because it's a very confusing message that comes out of the microbiology department.
Yeah, we're terrible.
So should we still carry on doing them?
Yeah, we are terrible with this, because we do give mixed messages. Even in my own department, and there's only 6 of us, we'd all say something different. But the recommendation, my personal recommendation, is if there's no signs of clinical infection, do not swab, because we get so many random swabs because they've got an ulcer. So that's one. That's an absolute. I think we all would be in agreement with that. Hopefully in the UK and globally. 2, if you're going to swab, then what we recommend is getting some sterile saline, scrubbing the top layer off, because it's just going to be colonized in Pseudomonas and coliforms, usually with a little bit of skin flora, and get to that red, swollen, infected looking granulation tissue, or the lack of granulation tissue, right at the base of where the ulcer should be healing from. And if we can get something from there, and it's a dominant one pathogen or just a couple of pathogens, or something that we know causes horrible inflammation within the cutaneous layers of the skin, then that's where the microbiology is gold dust. We can then taper things, and we usually see a good response with that. But a poorly taken swab will lead people down a rabbit hole, and they won't be able to, they will give people lots and lots of antibiotics, they get C. diff, they have diarrhea, and then they just recolonize all the way down the legs because they've got incontinence. So that's the point we don't want to get to. That would be my advice. That's always my advice.
And do you prefer, I presume, biopsy samples, and which is the best place to take the biopsy in an ulcer for culture things, like getting a proper culture results?
No, I'm not.
Or do you think biopsy is not indicated?
I'm not. Yeah, it's a really good point. It's one that I don't think I've ever been asked before, because biopsy probably still has the same. If you do a really good swab and you clear everything off that shouldn't be there, what you want what you can provoke getting at the granulation tissue or at the base of the ulcer on a swab should be absolutely fine. For example, when we get necrotizing fasciitis, we've had a lot this year in the UK. It might be because of the whole invasive group A strep phenomenon that we seem to have had. But when we get those samples come through, they have a myriad of everything, absolutely everything in them, and they're not useful. So we have to go and pick through what we think is probably going to be causing that necrotizing fasciitis, even though we know it can be polymicrobial. So biopsies will just give another focus for wound healing and bleeding that might not be actually beneficial for the patient. What biopsy is really good for is if we don't know the cause of the ulceration in the first place, then the pathologist can look at it. And if it's not just an inflammatory neutrophilic response, then it might be something like vasculitis or some weird and wonderful organism that might be there, or TB. So if we think it's TB, we would want a biopsy. But if it's just a standard venous ulcer that's infected, biopsies are not indicated.
Yeah, sorry to intervene. We have kept the Q&A session after all three talks are over, and then we have the panel discussion.
Sorry.
For half an hour. So we'll discuss all these things together. Yeah, sorry to interrupt. Thank you, Dr. Amit.
Take care. Thank you.
Thank you, Dr. Steve. Thank you so much.
Over to you.
Yeah, thank you, Dr. So now we have our next speaker with us, Dr. Suri. He is, myself, Dr. Amit, we were discussing about the role of a podiatrist in handling the diabetic foot ulcers in particular. So interactive with Dr. Suri, listened to his talk on January 21st, where he made a very impressive presentation. So I requested him to share his experience on this platform as well. So here is now the stage. Hand it over to Dr. Suri, please. Thank you.
Thank you, Dr. Gautam, and all the organizers for arranging this CME. I'm just going through it. It's a very informative and very nice group, which I am just seeing, and it's very nice. During COVID and post-COVID also, we in Indian Podiatry Association has been doing a lot of webinars, and I think that is the thing we really need to spread this point of education for our diabetic foot patients, and in podiatry dealing into foot care and foot ulcers and diabetic wounds. That I think we are today joined here in this webinar also, spreading education on diabetic wound management, some of the new things what we have been doing, and that's really what we have to share with our colleagues dealing into wound management. We all know that diabetes is a global epidemic of 21st century. And at present, if we see, there are more than 600 million people would be suffering with diabetes all across the world. And if we look at the data from our country, we are touching more than something around 79 to 80 million people. We should not be proud of that we are rising in number of diabetics in our country. And so is that when diabetes is increasing, now people have more insurance, geriatric group is increasing, good medical benefits are there. Medical facilities are there in smaller towns like Tier 2, Tier 3 city. So life expectancy has increased. And with the increase in life expectancy, that is the thing that we have more diabetic complications. If we look at retinopathy, if we look at nephropathy, or we look at diabetic foot infections or neuropathy, similarly CAD and peripheral arterial disease. So all is related to the mere core of disease. If you look at lower extremity amputation in our country, more than 2 lakh people all across the world, all across in India would be losing their legs all across because of diabetes. And if you look at shockingly, less than 50% of these amputees, they achieve mobility either because of not availability of the prosthesis department or podiatry departments, or not because of the cost factors. And we know diabetic foot infections are one of the costliest complications in diabetics. If you look at this slide and see, if we look at 5-year mortality rate, the bars in orange, first one is 45%. That is 45% is the mortality rate for neuropathic ulcers, and 56% is the mortality rate for neuroischemic ulcers. far ahead of any of the cancers like breast cancer, urinary bladder, colon, leukemias, or other prostate, only secondary to lung and pancreatic cancer. So that shows that diabetic foot infections or diabetic neuropathic ulcers have high mortality rate among our patients. And if you look at this staircase, if the first step, if you see neuropathy and PAD. So I think the take-home message of this webinar should be that how we can prevent, or we should be early identifying our patients with neuropathy, with peripheral arterial disease. Then only we can cut down this stairway to the amputation. If the patient has wounds, what are the new things? Like we have a new compound called Sepsil. We have used on few of our patients, and a lot of data is available now. And that is why early, if we can stop the whole vicious cycle by a good wound care product, so that the whole infection spreading to gangrene, compartment syndrome, underlying peripheral arterial disease, that all can be prevented if we are very active at the first stage of this stairway. Also, very important to understand, whatever we are doing, first 4 weeks of our wound management will tell us that our wound will heal or not. If in first 4 weeks, we have greater than 50% reduction in the wound surface area, that shows that 58% of these wounds will heal in next 12 weeks of time. If the wound healing is not proper, or it is not healing than less than 50%, that shows only 9% chances are there that our wound is will be healed. So we have to assess our possibility, that whether dressing is not proper, or infection is there, osteomyelitis is there, or the vasculature is not proper. So we need to reassess our wound care management. Also, early intervention is a key process. We need to see the blood circulation. We should be very active in debridement. I'll be sharing some slides on that. Infection control is very important, as we were talking on how to take cultures, how to take biopsy has to be done or not. Very important that how you have to take the culture. Never take the culture from the surface area of the diabetic wound or a chronic wound, like a bed sore. Our staff should be good enough to take the cultures from the deep tissue. We should always send the tissue for the cultures. That is very important in diabetic wound management. Offloading again is very important. Whatever we do, if the patient keeps on walking on that foot with a bandage, that wound will not heal, because when he is walking, the pressure is there on the foot, on the plantar surface of the foot, and that will not heal. Now, again, in wound management, moisture balance is very important. We need to maintain moist environment on the wound, where role of hydrogel is also very there. And that is where the role of the Sepsil also comes in, like to maintain a moisture on the wound bed. Surgical debridement, offloading, I said, infection, cultures, and removal of the biofilm. Very important, when we do the dressing, our staff should be trained enough to remove the biofilm, just curate it or clean with normal saline, or you have superoxidized solutions, you can clean with them and look for the, take the cultures from the base of the wound or from the periphery after the cleaning or removal of the biofilm. Osteomyelitis, probing to the bone is very simple. For the young doctors who are there in this webinar, whenever you see a wound, try to probe it. And if your probe is touching on the bone, that shows that 97% specificity is there, that that bone might be having some infection. Then you have to reassess yourself, get the X-ray or other investigation to be done and see if bone is infected, and then you have to treat according to that. Advanced therapies, like we have hydrogels, we have a lot of collagen fibers, we have foam dressings, a role of Sepsil is also there for the healing of the wound. And also we should be able to give good education to the patient for control of the sugars, and re-ulceration is important. They should prevent the re-ulceration, or diabetic footwear is important for giving to these patients. I think if you see these patients over here, thick calluses, these are the indicator of a high pressure areas. So never allow the patient to go back home. Just debride this with taking a scalpel, because that will indicate that the high pressure is there. If we don't debride, these calluses will break down, and sometimes they lead to the formation of an ulcer. So scrapping, giving them soft insole and any moisturizing cream, that should be the goal when a patient comes at that stage. Otherwise, what will happen if in the first photograph you see, if the patient keeps on walking on those calluses, you develop these neuropathic ulcers over there, and that is the time that the stairway I showed you, the infection will spread, osteomyelitis will occur. He can develop gangrene if he has underlying peripheral arterial disease, and that will lead to the amputation of this foot. So what we do, you do the debridement. Debridement and offloading are very important. These soles are given to the patient. We can take these U pads. These U pads are put under the sole, and these soles can be given inside the footwear of the patient. And then me or my staff will do the debridement. And here you can see this is the right foot of the same patient after 3 to 4 weeks of time. After debridement, after giving them in insoles, offloading done, and the ulcer has totally healed. Similarly, you see this is a patient who was walking barefoot, and this lady had a total collapse of the medial arch, and the nail went through the footwear of the patient, and big abscess was there. So giving education to a diabetic patient is very important rather than going for the treatment for these type of big ulcers. We have to do the debridement, and then we have to apply a VAC therapy. VAC is something, a very good, innovative way. A lot of people in this webinar would be knowing about it who are doing into diabetic wound management. VAC, we apply open-celled foam, and we apply a tube here. And this open-celled foam, the suction occurs on the wound surface area. We send the patient back home, or this VAC is removed after 6 days. And when we remove the VAC, the wound, subsequently the wound tries to heal like this, and good granulation develops over there. And then early you can do a graft like this. And in the last photograph, you see within a span of 8 to 10 weeks, we were able to close this wound. So this is somehow that vacuum assisted closure is a unit which you can use that on these type of patients. This is again one patient where callus has developed in the first photograph. This patient needs an orthotic. He is wearing a hard shoe. He is diabetic. He has peripheral neuropathy, total numbness in the foot. He is not able to have the sensation in the front, whole of the front. And then subsequently with the petechial hemorrhage in the second photograph, and he came to me after 3 weeks, you see an abscess cavity, and the whole infection spread to the head of the second metatarsal, and one of the toe has to be amputated. So this is something that early referral to a surgeon is very important. Early referral to a podiatrist is important. Giving education or giving insoles to the patient like this is very important. So you should be very active in that, and so that we can subsequently prevent amputations of these soles. We have a lot of non-infected diabetic foot ulcers where nothing has to be done. Do not give any antiseptic solutions or antiseptic. This Sepsil is good enough to give in this patient, and also we can give them hydrogels, and these ulcers will heal in 2 to 3 weeks of time. Then you have neuropathic ulcer like this. Again, moisturizing cream is a role for that. Then you have infected diabetic foot ulcer. This is a very important stage when the patient comes to the wound care department or podiatry department or to a surgeon, like patients with this. In the third photograph, you can see a slimy layer. This is a biofilm, very important. The fourth photograph, again, you can see a slimy creamish layer. This is biofilm. So you should be able to remove the biofilm. You should have the product which is you have where you can remove this biofilm. So Sepsil could be one of the very good indicators here for removal of the biofilm. And then subsequently, you have good granulation tissue can be developed. We need to have oral or IV antibiotics, but offloading is very important in these type of patients. Third type of patients are ischemic diabetic foot ulcers. I'm going one by one very fast because of the time constraint, but these are very important steps when you are dealing into wound care, that at what stage the patient is coming. Ischemic diabetic foot ulcers are like these. Patient developing gangrene in 2 toes, gangrene in the heel or in the heel area, first toe, underlying. As I said in the first staircase, that identification of peripheral arterial disease is important in this patient. We should be active enough to indicate that, and that's how we can prevent these gangrene. When you have these patients, we need to have debridement, but first we have to maintain vasculature. We have to think of the vasculature, and we have to get CT angiography, MR angiography, or Doppler scan. The simple Doppler scan is available in every city, every corner, and every clinics are available. Smaller nursing homes have this, and we should be able to use this modality for our diabetic foot patients. Third is infected and ischemic. I think I am in practice for so many years, but still when a patient comes to me when an infected and ischemic diabetic foot ulcers, I am also scared at this stage. These are one of the patients like these. When necrotizing fasciitis spreads like fire and whole of the foot is involved in 2 to 3 days of time. So early action in these ulcers are very important. Also at our periphery, at a general practitioner level, those doctors should be good enough to refer these patients very quickly to the higher centers where we can save this patient from there. You can see with a tight shoe, this patient in the second photograph has a necrosis on the first toe. A debridement has to be done, and then we subsequently VAC is applied. So there again, VAC is very important if you have to do a proper wound care. And you can see this granulation tissue which has developed after proper wound care department, and then we have done the grafting. This is one of the patient, again, ischemic foot ulcer, diffuse peripheral vascular disease. And we did the debridement. We did send this patient to a vascular surgeon. We got an endovascular procedure and look at the good granulation tissue which has developed in 6 weeks of time. We did the amputation, we did the grafting, and this is a foot after something around 8 to 10 weeks of time. This is how we can save the foot from amputation. Otherwise, this patient was initially, I also advised him to go for a below knee amputation, and similar advice has been given to him from the previous doctors also, but we've saved his whole foot by advanced techniques. This is one of the patient by post-amputation stump came to us from another hospital. This is wrong amputation done for this patient. In fact, below knee amputation should be done, but this patient didn't give us the consent for that. We applied VAC and we did PRP. PRP is one technique where I take the patient's blood, centrifuge, we separate out the buffy coat and put that buffy coat in the wound in the first photograph you can see here, and look at the granulation tissue which has developed again in 6 weeks of time. And then we did dressings with Voxil, and then ECM, Dermacell or Integra or Matrix. These are dermal matrices are available. We can apply that. But at this stage, again, what we are here for this webinar, sepsil could be one of the indicators. I would have, if I would have, this is something around 2 years back, but I would have used this product and that would have given me a better results at this stage. And then grafting has been done. And this is a photograph after about 3 months of time. So great hard work needs. It's a comprehensive wound care, sugar control, infection control, offloading. Then you need to have proper dressings in your kitty. You need to have what type of sheets to use, when to use hydrogel, when to use fiber like Purilon, Python AG or other fiber sheets are available, when to use these extracellular matrices, and then how we can save these patients. We sometimes have these patients where we can, this is Charcot's foot, and we have impregnated this vancomycin beads, collagen beads are available, and then VAC is applied. And this is how we have been able to save this patient from major amputation. Here we are using this fibronectin. This is fibronectin is a natural protein in our blood, and that protein has been indigenously made, and spray has been used for these patients. So biofilm, again, diabetic foot is a big problem. You can see this. And here you see biofilm. This is very important. So sepsil could be a good indicator here to remove the biofilm, curettage, wash with normal saline, and then whatever dressings you want to do, you can do in these type of patient. This is again one of the patients with bilateral gangrene. I'll go fast with this patient. We did the debridement like this, and then VAC was applied on both the feet of this patient. PRP was given to this patient, and then Integra was applied on the sole of the both the feet. And this is how Integra we are making half by half, and then applying, and then again vacuum-assisted closure is applied. And this is how the granulation tissue, a thick dermal matrix, is developed after 2 weeks of the application of these dermal. You can see the first photograph, and subsequently after 2 weeks, good dermal matrix has developed. Then we applied the graft. Again, VAC is applied. This is on the other foot, and subsequently in the center photograph, you can see the foot of these patients. So these are how sometimes we have to use a lot of things, lot of complementary thing, comprehensive wound management to bring this patient from this stage to this stage. And that's how we can then. And then offloading is very important. Role of a podiatrist and a wound care center is very important, where we can devise this, and then rocker sole has to be given to these patients, and that's how we can make this. PRP, I think everyone in this webinar should be good enough or learn that this technique of PRP, we can take patient's blood, centrifuge, and separate out the plasma. This is daycare procedure, just takes about 10 to 15 minutes or 25 minutes for the centrifuge, separate out and put it in the subsequently in the subcutaneous tissue all around the wound, and then we can take. If we have time to continue, or I can close over here, please. Just few. Okay, a few slides on that. This is Actigraph. Again, we separate out patient's blood. This is a very good daycare procedure, just OPD procedure. We take patient's blood for this wound like this, which is not healing. We mix it with calcium gluconate and make a gel. This is a gel of the patient's own blood. The technique is we are taking out all the growth factors from the patient's blood and take out, and we are putting that in the wound of the patient. So again, this is one of the companies called Red Dress from US. It recently launched in India, but we have done about something around 20 patients, and excellent results. We have the granulation tissue or the wound bed preparation occurs in about 3 to 4 weeks of time. Dermacell, again, I want to pass on that, where the bones are exposed, there we can use these techniques of derma cell implantation and subsequently take the help of VAC therapy also this. So I think to prevent amputation, debridement is very important. We should not be scary. We should remove all the dead tissues from the wound bed. Infection control, yes, culture has to be sent from the base of the wound. Never take culture from the periphery or from the surface of the wound. Glycemic control, role of a physician or diabetologist is very important. Until unless sugar is controlled, no wounds or no chronic wounds will heal. Offloading is must. Use of new treatment modalities like VAC, PRP, hyperbaric again is very good for peripheral vascular disease. Newer dressings are available, amniotic membrane, dermal matrices, stem cells we use a lot, and drugs like hydrogels and Sepsil, you can use that. Vascular intervention, we should, if our ABI index is less than 0.9, if a Doppler scan is showing some circulation is less in this patient, we should be in the process of consultation with a vascular surgeon. Footwear, patient education, and then prevention of ulceration is very important if we have to heal these patients. Thank you so much.
Yeah, thank you, Dr. Suri. So we can take the, so it was showing the kind of experience that you have as a podiatrist in treating these leg ulcers and especially the diabetic foot ulcers. Thank you so much. We will have the Q&A and the panel discussion to take up the questions. Now this stage is for Dr. Vijay Sharma to please chair the session for Dr. Bawa. Thank you. Dr. Bawa, who is a renowned surgeon and is working at Ludhiana in DMC, and he is in particular handling the wound patients, a big number every day. And so I would request him to share his experience of treating wounds and using the AI for that. Dr. Bawa, please, on behalf of Dr. Vijay, I'm inviting you. Thank you.
I'll be talking about the third eye. This is something like hum jisko teesri aankh kehte hain. So wound cameras for me are the third eye. Third eye means it's called the mind's eye or the inner eye. It's a mystical, invisible eye, usually depicted as located on the forehead, which provides perception beyond ordinary sight. For me, wound cameras are the third eye. So it gives us that vision for wounds that we don't usually see, the things that we usually don't understand. The topic is what is possible. So these are recent advances in the field of wound management. The only disclosure that I have to make is that I'm not a plastic surgeon, but a general surgeon who's perhaps in the ladder of hierarchy in my hospital was the second lowest. So all calls for wound care used to go to me. So there were diabetic foots, there were bed sores, there were neglected wounds, venous ulcers that had to see. And I converted this thing of wound care into my passion. So wound care is basically the most visual and passion-filled specialty of healthcare. If you do it properly, and you will have results, and you would be able to document the progress. That's what wound cameras do. And they say a picture is worth 1,000 words. And what are the various spectra of wounds that we see in practice? There's surgical site infections, post laparotomies, or abscess drainages, or other things that we do. There are burn wounds, there are skin and soft tissue infections, including cellulitis, diabetic foot ulcers, and then there are pediatric and neonatal wounds. So the first device that I'll talk of is this iPad with 3D sensors. This is by a company called eCare. This is a US-based company. I wrote to them about my passion for wound care, and they were happy to help me with the device. This gives us about the length, breadth, and depth of a wound, and we can properly document the progress of wound, what is working for the wound, and then you can always have a graph at the end, or perhaps export all your data to look at what works and what doesn't work. So they say seeing is believing. So one of the patients that I would wish to present is this patient with an open abdomen. Patient had a laparotomy done outside, came to our emergency in shock. There's a stoma in situ, and this was the wound on day 1. This is on 11th of October, 2022. So with one session of VAC therapy, I was able to get this wound to this. So again, if you want to have a look, this is area is 115.7 centimeters square on the 11th of October. So after one session on the 18th of October, the wound was 67.6 centimeters square. On subsequent imaging, we were able to document the size and reduction in size of the wound. So the area became 65.5 centimeters square on 26th of October. On 15th November, the wound became, the area became 33.8 centimeters square. So this is what the camera does for us. It gives us a proper representation of decrease in size. And you can have the data. It is very easily accessible through a web browser. And this is the last picture that I took of the wound. So just with VAC and dressings, we were able to reduce the size of the wound. So one could do day-to-day monitoring of wound. So we were able to use Sepal in this patient also. This is a diabetic foot ulcer, non-healing. You can see dead necrotic tissue. It is telling us that the yellow part, the necrotic dirty part in the wound is about 75%, red is about 12%. With one session, with some daily dressings, we were able to, get proper granulation tissue in the wound. Then we used again VAC and dressings with Sepal. The subsequent dressings, we were able to make the wound granulate like this. The red became 66%. Then I put a skin graft on the wound, and the final picture of the wound looked like this. So we imaged about 196 patients and total wounds. Some patients have double wounds, dual wounds. So total wounds that we're looking at 249 from this device. So this has given us, we're able to do proper documentation of the progress. We know that what we're using Sepal, we're using microdocin, we're using silver-based products. We're able to do proper documentation of this wound. So again, a patient with this guy had polio, non-healing ulcer that I debrided. So I used a Sepal solution in this patient. So these are pretty recent pictures. This is 20th of February. Again, this is the patient's wound. So this has granulated well. Again, the wound is on the 23rd of March, the wound is looking like this. The patient is not interested in skin grafting. So the final picture is like this. So again, from 30th March. Again, a large gluteal wound that was treated with VAC and Sepal. So these are pictures, and you can see the subsequent decrease in size of these wounds. So if you're able to properly document progress of a wound, we know what is working and what is not, we would be able to reduce healthcare costs in the patients. So another new thing that is happening is that we can detect wound infections using artificial intelligence in these wounds. We can detect autofluorescence that is released by bacteria, and this can be captured by these cameras. And we can know whether the infection in these patients is a gram-positive infection or gram-negative infection. So we can, it helps us in tracking treatment efficacy. So these are some of the wounds that we have used and imaged using this AI-based device called Illuminate. So this is a diabetic foot ulcer. You can see that green area in between, which according to the device, when it shows green, it means gram-negative. We've been taking tissue cultures from these wounds and imaging these wounds. This was another diabetic foot ulcer. It showed mixed infection, gram-positive as well as some gram-negative as well. So with regular dressings, we were able to take care of, you could see the decrease in infection in these wounds. By the way, Sepal was being used. This is another patient with a chest wall infection, where you can see gram-negative in the periphery of the wound. We again took tissue culture, it showed E. coli. So if you've seen that with subsequent use of Sepal, there is increased granulation tissue and decrease in infection as noted by the AI device. So what is possible in this future is that we might have tissue oxygenation that can be documented by using this device. We would know what is dead necrotic tissue, what is healthy tissue, and further debridement in wounds can be planned. So once you are documenting your wounds properly, you can get families involved. Patients would know that the families would know that something is working or not. So they're involved. So there are less chances of getting involved in medical legal tangles. All this data can be used in medical research and education. So this is another gluteal wound where you can see gram-negative infection. So with VAC therapy, we were able to reduce gram-negative infection in this wound. So see, from this to this. Again, this is another wound that we treated with Sepil. You can see gram-positive infection in the periphery, gram-negative, a bit of gram-negative infection as well. So with subsequent dressings, there is a decrease in bacterial load in the wound. Another of the wounds that we treated, you can see gram-negative infection. And with the use of Sepil, we've been able to reduce the infection from the wound. So these are the few papers that have been published on the device. We've been working on thesis, and we're working on a lot of studies, and we're trying to collate our data and trying to publish our work with regards to the novel AI device. So most of our infections have been gram-negative, about 43%, no growth in 44%, and a mixed gram-positive and gram-negative. This has been very interesting. Some of our patients have a mixed infection of MRSA and Klebsiella. So it is very interesting to note. In fact, I showed a slide with this infection. So almost these are the imaging sessions that are being done every month in my wound care clinic as well as in DMC Ludhiana. A quick word about there are other devices like Moleculite and Wound Zoom that do the same function of these devices, but Moleculite does not give you gram-positive or gram-negative in the wound. So this was just my talk on wound cameras, and I think so a lot is possible, and they'll be very helpful with regards to documentation of wound progress is concerned. This solution holds a lot of promise. Last year, I've been using a lot of it in my practice, and it holds great promise. And I congratulate Dr. Vikas Gautam for coming up with this brilliant product. Thank you.
Okay, what a wonderful presentation. Dr. Ashvind, I could not invite you at the beginning, but it was really wonderful presentation. So any questions from, there are so many listeners. This was really need of the day, I think. In a busy day schedule, more than 85 people are online listening to these talks, important talks. So any questions from rest of the listeners? So just one small point from my side. In AIMS, we have a dedicated wound care nursing system. So at your place, who is managing wound management there? It's mainly the nursing staff you have trained, or people you have trained, or faculty has to do, or residents, they have to do everything?
Yes, sir.
So the question is directed to whom, sir?
Both Dr. Suri as well as Dr. Ashwind.
So, sir, I'm working with DMCS faculty, sir, and wound care is a very passionate part of my life. So right now, we've given 2 theses to our candidates. One is on autofluorescence device. The second is on wound anthropometric data comparison between manual methods and this 3D wound measurement. So I have a team of a junior non-PG resident who's interested in research, who's doing most of the documentation. Luckily, sir, we are allowed to practice at home by DMC. We do OPD practice, and I see a lot of OPD patients at home as well, about 20 patients a day. So my staff, I've got 8 staff and about 8 vets, and they help in proper documentation. There was a time when my iPhone camera was the only device I had, and my family pictures and my wound pictures used to get mixed. So now with these dedicated devices, at least my family is also happy and my patients are happy.
Okay. Thank you.
Yeah.
There is no question from my side, Vikas. So if you want to continue with the panel discussion, you can.
Yeah, sure. Thank you, Dr. Vijay. Thank you, Dr. Bawa. It was really very nice.
It was a very good presentation. Mainly yes. that sensing gram-negative and gram-positive, I think that was something very new to us. The wound cameras, definitely, I think I have heard about them. I know that is of use for research and wound monitoring, and for looking at success of your products and everything. But this gram-negative, gram-positive, and color and AI part, I think that was quite new to us also. So thank you, Dr. Bawa. Thanks.
Thank you so much, sir. Thank you for the kind words.
Thank you so much, Dr. Bawa. So now, Dr. Suri, Dr. Amit Sharma. So Dr. Neeraj Jain. So what we can do now, we can start with our Q&A session and as well as the panel discussion together. So to the audience, I'm seeing some of the questions in the chat box. So I'll request the audience to please post your questions in the chat box and we will take them up one by one. So first, taking the questionnaire from the audience that comes from Dr. Remini, whether SAPL is commercially available. So yes, Dr. Remini, that is there, as Dr. Bawa has shared his experience of using this SAPL. So as he shared that by now, I tell you, I met Dr. Bawa just on March 10th when I had a talk at Garhwasi, Ludhiana, and happened to meet for just, I think it was just a very short visit of short meeting of us just for 10-15 minutes, that's all. But then looking at the literature for the sample, he was already ready with his patient and he said, I'm already waiting for the samples. So I appreciate his promptness and this thing. And today, within just, it's 16 to 31st, today is just 15 days and he has already enrolled 16 patients. And,
so 10th day. So we met on 10th of March. I checked the timeline also. So
yeah,
10th to good
10th of March, but 16th you ordered कि yes, now I need.
So I had samples from 10th of March to try, sir. आपने दो sample मेरे को पकड़ा दिए थे. So we had access to them and we started using them in the clinic. So we were rationing them and I was, for the first 2-3 days, I was like, I wanted to open the dressing every day and see whether it, what is happening with the wound. So is there any infection or not? I believe in the sense of smell and visual a part of the wound, whether there is the wound is getting septic or healing or that ways. So wound seemed very, the product seemed very, very safe to be used. So immediately then I called you that I need a product to be available commercially. And you were kind enough and gracious enough to supply us in 2 days. And most of the patients in rationing chal raha tha, we were able to give them. And some part of my practice, these patients go for domiciliary care also. So they send me images also from their on the WhatsApp also. So we are documenting, and perhaps for the next presentation, I will have completely healed wounds as well for you, sir.
Oh, thank you so much, Dr. Bawa. I mean, that was just at a very short this thing. You said, no, I'm ready to share my things for the benefit of the audience so that others can, they're also struggling in treating these wounds, and it's a day-to-day challenge. Well, thank you for this thing. And I think the next question is also being answered as asked by Dr. Kalpana Elizabeth, and would like to know how much a clinical microbiologist can contribute. So I think Dr. Kalpana, it is being answered that as a clinical microbiologist, we help our clinicians just like Dr. Bawa has been helped, and this is how we can contribute. Because, you know, going back to some almost 10-15 years back, we started at PGI the bedside ICU rounds. And today is the day that started from by one faculty and this thing, and now the whole department is interacting with the clinicians. And that's the kind of rapport that develops. That first, yes, आपको ये रहेगा कि आपको clinical microbiologist अगर आपको बनना है तो पहले आपको थोड़ा सा extra labor has to be done, because अभी हमारी जो इंडिया में teaching रही है, that is the more the lab based, but yes, now it is being recognized. And as we heard in the first talk, the conversation between Dr. Steve and Dr. Amit Sharma. So this is how the things, I think Dr. Steve can also contribute to this question. Dr. Steve is there. Or, yeah.
Sorry, I am. I'm telling people to ring me at the normal call times. My apologies. The question was, how can a clinical microbiologist help in the whole of this, isn't it? So we in the UK, clinical microbiologists were now trained a little bit differently than how it was 15 years ago. We were physicians who are part of the Royal College of Physicians, and we're also pathologists and microbiologists through the Royal College of Pathology. So we have to do both of those exams. That helps because it's easier to go to the bedside to see the degradation of the foot or the leg or the sacrum or the armpit or whatever, make some form of clinical decision, help people take appropriate samples, and then take that information back to the lab, knowing that you know the patient, and be able to taper therapy that way. The other role that we've got is teaching. That's why I'm doing this. And the third role that I think a clinical microbiologist has is research, is to be able to help stimulate research in infection topics. There was a comment there from our colleagues who said that he trusts in smell, and we used to in the lab, we used to smell plates all the time, but then people used to get infected with brucella and stuff like that. So we don't do that anymore, but you can actually do research topics on looking at volatile organic components and do eNose testing. That's something that I've just recently done with COVID. So we've got a huge amount of things that we can do as clinical microbiologists. We shouldn't just be thought of in this world, and I know it's different in different countries how you're set up, as people who are sat on a phone or in a lab pipetting and plating. It's not it. Going forwards, it shouldn't be our role. We should be more hands-on. We should be engaging with our colleagues, our surgical colleagues, our diabetic endocrine colleagues, and we should be treating our patients in a multidisciplinary team approach, because we all have something to bring. And I think this session today showed that each part of it was individual, but it really did wrap around a topic in a very holistic way, and that worked well.
Yeah, Dr. Amit, you have to add on to something.
Yeah, actually, I just wanted to make an observation. The chronic wound healing has been around. I mean, the problem has been around since human beings have been around, and we have struggled with the treatment. As you would recall, even in the Vedic times, we have seen pictures of various lapes and mixtures being made, and even in the modern medicine, we are still struggling with trying to find a proper answer to that. And I think if you look at the modern medicine, probably wound healing is the only place where we have been open to so many experimentations. We have taken up honey as a treatment. We have taken up silver. We have taken maggot therapy as a treatment. We have taken up PRP. Even amniotic, membranes have been used. So we don't have an answer. We're still struggling to get that. And I think in this field, we are very open to use Ayurvedic medicine as a mainstream. And Sepil, with its promising result, I think has a potential to become a mainstream treatment for most of these or many of these. Of course, we don't foresee, or it's difficult to treat everything with a single treatment, but I feel that Sepil will be a very important part of the armament that we have against all this difficult problems that we deal with. So it will be nice if you could tell us at some stage about various products that are available. Do you just supply ointments, or is it fluid, or is there any dressing that you have impregnated with this Sepil thing, and how does it work?
Yeah. Thank you, Dr. Amit, for the kind words. Actually, I share with you at present, as Dr. Bawa has shared the image, it is available in the oil form. But yes, already we have some 8 to 10 institutes who are now working on this Sepil. So in the different formulation also, we have already developed the hydrogel in collaboration with the Nano Institute as well as with Punjab University. So we are working on the different formulations, which will soon also be floated for the patient benefit and being commercially available. And I tell you, as you have pointed out, the kind of indications that it can have, not answer to all the problems, but I share with you that one of the surgeon 2 months back asked me from Delhi whether this can be used in necrotizing fasciitis, 4 years gangrene, he asked. My answer at that time was clear-cut no to him, that this has not been used. But yes, just after 15 days, I got the images from an orthopedic surgeon in Chandigarh, and he shared those images being treated for the Fournier gangrene, and I showed those images to Dr. Bawa. So I said, you please let me know if this kind of bad Fournier gangrene is there, how much time will it take? So if I'm correct to recall, Dr. Bawa commented at least 4 or 5 months, right, Dr. Bawa? Right, and yeah, Dr. Bawa, please.
Absolutely, sir. And I was surprised at the result that you showed, sir.
Yeah, and besides that, I asked 2 or 3 more orthopedic surgeons. They said minimum 2, 3, 4 months it will take for such a gangrene to heal. And the sample, as that orthopedic surgeon has shared even on the WhatsApp, within 10 days, the whole scrotum skin was normal skin without any graft. All it has appeared. So we have done trying to find out the answer. How is it working with the Netherlands group? We have made the animal model. We did the biopsy mice experiments. And there, the pathologists were also surprised to see the mechanism. So still things are on the research part on one hand, and now you clinician colleagues are helping me out, and that has become more satisfying for an innovator and my team, that you guys are satisfied. And this is how, as has been asked, how clinical microbiologists can help the clinicians, because this is what we were observing at the bedside rounds. Another interesting part, what Dr. Suri has pointed out in his slides, that the antibiotics, Dr. Steve has stated in one of the antibiotics don't promote wound healing as per the NICE guidelines. Well, that's what we're trying to find out, because there's a common question being asked by the clinicians कि भाई मेरे तो इसको wound हो गया है, इसको infection हो गया है, और उसके बाद I have to give antibiotics also systemic, right? Now there is a paper which is available right from 2002 that antibiotics delay wound healing. One thing we have to remember. So if it is a localized wound infection, never give an antibiotic, number one. Number two, with Garvaso Ludhiana, we have conducted a study in 32 canines, and there one of the arm was the topical agent plus antibiotic or topical agent alone. And you'd be surprised that when we have clubbed the antibiotic, there the wound healing has been delayed. So this is another message we'd like to give to our clinician colleagues, that avoid the antibiotics unless and until there are systemic signs and symptoms. Thank you. So I hope, Dr. Amit, I have answered what you have asked for. Well, there is another question. I go back to the audience by Dr. Ambika. Well, Dr. Ashvind has replied, but if she is further any query, she has asked, have these fluorescence results been correlated with cultures? Dr. Ambika, if you, Dr. Ashvind has replied, yes, doing directed tissue cultures. Would you like to further ask on this? I think we cannot unmute the audience. So, Dr. Ambika, you can write in the chat box if you have further query. Yeah. So, well, Dr. Steve, I want to ask you something that Dr. Suri was showing during his slides, that when there is a slimy layer and you have this biofilm, which is again a big challenge in the wounds. So, Dr. Steve and Dr. Bawa, how do you make out, like Dr. Bawa, you have shown that this how AI and the cameras can be used. So do we have any provision of identifying the biofilm also with your AI and this thing? And Dr. Steve, you can add to it.
So early results, I spoke to the innovator who made the device also. So she's been able to convince me that this is biofilm. With some of the images, you see a mesh-like layer with regards to these gram-negative, the green infections. It seems like a mesh sometimes over this. So I'm still yet to be convinced that whether it is biofilm or not. These are very early days for the device. We are retrospectively looking at the images that have been able to click with the device. I may be able to answer you perhaps in the next 2-3 months, sir.
Oh, okay, great. I will wait for it. Thank you. Yeah, Dr. Steve, you have to do something, and then Dr. Suri, please, for his comments.
Yeah, I mean, commonly there's 2 gram-negatives which will create a really good biofilm, which can be either protective in some ways to stop other bugs getting in, or it can be absolutely inhibitory with regards to healing. So it kind of keeps things static and hopefully doesn't help break down. And that's Pseudomonas aeruginosa. That's when you get that horrible, offensive, bluey, greeny hue that's commonly seen with Pseudomonas, or the really mucoid Klebsiellas, which if you grow them on a petri dish, it just look like mucus. They just look like snot. And they can cause a lot of problems as well. A lot of the gram-positives can cause it as well, but they usually need a plastic service, so the coagulase negative staphs can cause biofilms on things like prosthetic heart valves. Taking it off, though, seems to be, from what our colleagues have said here today, taking it off is the way forward. And how you do take that off, it's been explained a couple of times, either with normal saline, acetic acids, etc., 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 etc. There's many ways of doing that, hyperoxidase solutions. But I think the general consensus is that we're coming to is biofilm is a nightmare. And if you don't take it off, you can't get something clean. And if you can't get it clean, then you can't get it sterile. If you can't get it sterile, you can't get it healing.
Yeah. Dr. Suri, you have to add to something? Actually, the question has also appeared in the chat box. Dr. Steve, you have been pointing out about the challenge with these biofilms. Well, the researchers are working almost throughout their lifetime that to find out an answer to break this biofilm, and still our clinician friends, they are still struggling. Well, the question asked by Dr. Dipanshu is, does Sepil work on biofilm? Very much, Dr. Dipanshu. And I must share with the gathering and the experts that just next month in the ECMED, the European biggest conference of microbiology and infectious diseases, our paper on breaking the biofilm by Sepil has been accepted for presentation. And what we have shown, we have clearly shown by the crystal validation as well as the scanning electron microscopy that it can very well break the biofilm produced by the Pseudomonas aeruginosa. So there also, and as the now clinician friends have shared their cases, that we have treated the bed sores with the biofilms, and one of the HOD from PHI from surgical department, he had shown in February 2020 in CME that bed sore 95-year-old female patient with bad Parkinsonism. She had a bed sore and there was a slimy layer on it. And on the very 5th day, that is what now had become his favorite slide, that you could see the sinus inside. So the Sepil, that was a 3-month long bed sore, and within 5 days, that slimy layer, the biofilm was broken. And then as the patient attendant shared, they said, you gave us a very small sample. So what we were doing, we were just adding a small amount of Sepil we could do, and within 40 days, the complete bed sore that got healed without any need of the graft. So yes, the Sepil can break the biofilm. Well, there is a next question, Dr. Ambika. If cultures taken properly as recommended yield similar bacteria as surface ones, do we go for antibiotics? Yeah, Dr. Bawa, you can take up, then I'll come to it.
So one has to decide with regards to the wound's current morphology and the status of the patient. If you are if you've taken tissue cultures that are positive and the wound is not healing, so definitely we should put patient on antibiotics. A short course would perhaps sometimes do wonders and take care of the deep tissue infections that are there in the wound.
Yeah, thank you. So, Dr. Ambika, one thing as a clinician, we should remember that your wound is colonized also, right? Don't try to make it sterile. Rather, there are papers which have described the mechanism, how the commensal flora on the wound is helping the wound to heal. So it doesn't mean that if you're getting a bug and it is actually causing the infection. So your wound may be not healing not because of the bacteria, because these might be just the colonizers. So case to case basis, we have to find out, and Dr. Steve has also shown in the nice guidelines. It is not basically in a broad way what we say. That's what Dr. Steve has pointed out when Dr. Amit asked that we are being, it's a challenge whether to swap of the every wound to be sent or not. So I can repeat what Dr. Steve has recommended, that if your, as Dr. Bawa has also applied, that once your this wound is healing, then just in a meeting. So once we are having this wound is healing and your colonizer is coming, you need not do anything. And there are no systemic signs and symptoms. So one need not. Yes, when you have a non-healing ulcer, your challenge is there, then you have got a green slug that like typically in burns patient, you have Pseudomonas again there. It is very well recognized fact that in burns patients, you don't give systemic antibiotics, even if your wound is colonized with Pseudomonas, depending on, yes, the stage of the patient. Well, anything to add from Dr. Steve?
So just a quick word. The device that I'm using, Illuminate, tracks only infections 10 raised to power 5. So one would know the difference between colonization and in fact infections that are coming in. So it is one thing that they've taught the AI algorithm to read infections to the more than 10 to the power 5 only.
So that is, I think, that would be really helpful for if this camera device is available freely, and most of the physicians start using it, most of the surgeons. So I think it would be of great help. And as a clinical microbiologist, we would also be really able to help you all.
So, ma'am, luckily, our department, microbiology department, Dr. Vinu, Dr. Jyoti, ma'am, have been very helpful and very enthusiastic about helping us with the tissue cultures and quick reporting, so that we can come up with authentic data with regards to device. I call it, in the talk also, I called it the third eye. It is more like a stethoscope for a wound care physician.
Exactly. So that is what I was wondering. With the camera, if you are able to detect this gram positive and gram negative, and if it is being correlated with the cultures as well, then it is something really unique and very good.
So one can always see whether whacking or sepalling, used, is working or not.
And I really want to use this platform to congratulate Dr. Vikas Gautam for SEPEL.
Well, thank you so much, Rambika. Yeah. I tell you, just in continuing with your query, that MRSA, as Dr. Steve has pointed out, is less in UK, but yes, more in the US. Well, in one of a breast carcinoma patient who had been done the mastectomy in by mid-September, her wound got infected with the MRSA. So everything was tried in that patient for dealing with the MRSA, and repeatedly MRSA was coming from the swab. Now there you have to go with the culture when the wound is not healing. Otherwise, the patients who had been done the routine mastectomy, they have been discharged without any this thing. So there, then everything was tried on the patient. Finally, that we have already put into the submission, that manuscript for publication. So then first tried your ciprofloxacin, then it was linezolid, being given systemically in that patient. So there you have to give, and then finally VAC brain, and then finally when still not healing by November it came, then the plastic surgeon placed a rotation flap. Even that was necrose. Now there is nothing left in the armamentarium to treat it. Then finally our ethics committee approval and all came. Then SEPEL was tried, started on 26 December. January, February, only SEPEL was applied, no systemic antibiotics, nothing else. And first week of March, this patient went for radiotherapy. Now, there are two important observations from this. One is mupirocin is the sole local antibiotic. Dr. Steve would agree to me that is available for treating MRSA as of now. But the limitation with mupirocin is that you cannot apply it beyond 10 days. Because it leads on to two things. One is AMR resistance, and the number two, the PEG in that it can knock off the kidneys of the patient, being a topical agent. But here, this sample we have used, and we did the RFT also later on of this patient, which are found to be normal in this. And then we try to find out the source of the MRSA. That's what Dr. Lipika, who is the co-inventor of SAPL, pointed out, that let's take this swab. So we took 6 swabs, one from the nasals, one through axilla, and 2 from the breast pieces. 6 of these samples, 4 of them grew MRSA. So she was actually the colonizer with the MRSA. And that was not letting her wound be had. Initially, it was a very small wound. We didn't have the equipment like Dr. Bawa. But yes, what the staff, she was a staff mother, she told, unless you were very just 3-4 centimeter wound, but later on, deep down, they used to have to put in the glove with the hands, and the pus used to be extracted out from such the wound got that deep and big. Well, thank you. Dr. Steve, you have to add to something.
I was just going to say my true believing, and I'm sure we'll get this answer in the next decade, is that biome balance is the ultimate thing we should be striving back for. So your points on don't try and completely sterilize something down is appropriate, because the differences that we make, if we all know how C. diff colitis works, we alter the biome of the gut, we take out the good bacteria, or at least we change the percentages around and give that space for that Clostridium to grow. It's the same with Staph aureus and coagulase negative staphs and the Crinese and all of the other bacteria that live there. They live in a certain proportion and they live relatively in harmony, and they actually will promote good skin health. Without having bacteria on us, we wouldn't have good skin health. We'd probably have eczematous diseases and our skin would fall apart. We do need to live with our viruses, our fungi and our bacteria. So I think it's a good point that you make, and that's just what I want to go back to, is that we don't give this a huge amount of consideration in skin, because everyone gets worried that the skin should be completely and utterly void of bacteria, but that's completely not going to help a natural skin to reform, recolonize, and be protective. Yeah, that's basically the point that I wanted to make.
Sorry. So now I think we're almost done, and if there is any pressing question, we can take it, or I think we can wind up. We had planned up to 3:30, so we're already 7 minutes past 3:30. So if Dr. Neeraj is there, or shall I take this opportunity to thanks all my speakers, Dr. Steve, Dr. Suri, and Dr. Bawa at such a short notice, and within just with 3 weeks data, he is all there with his AI and cameras. And Dr. Suri, it was a pleasure listening to you again. And Dr. Steve, yes, I still remember September 21 when I had you first and bothered you once again. And
I'll see you in Copenhagen. I'm going to put a little plug out there. If anybody is coming to Copenhagen next mid and they want to see me talk about COVID VOCs or about reducing your carbon footprint by going to oral antibiotics away from IV antibiotics, come and see my talk after, of course, they see your talk on Settle.
Okay. Well, looking forward to see you there. Well, thank you. Yeah, Dr. Neeraj is there. So Dr. Amit Sharma is the chairperson. Yes, he handles well, and it makes a good combination when you are there. And with your very comments, very balanced comments, and we learn from you as a clinician being in UK and how your microbiologist is helping you out. Well, Dr. Vijay has to leave due to some urgency in the middle of the discussion. So I also thank him in his absence that yes, Dr. Vijay Sharma is the principal investigator for the ongoing clinical trial for SAPL in the wounds in his orthopedics department. So, well, thank you all. Yeah, Dr. Neeraj.